that I moved south of the River Thames to the Maudsley Hospital and the Institute of Psychiatry. And for the first few years, I was working in a community outpatient job at the Maudsley, looking after people with treatment-resistant schizophrenia, and a lot of my job was facilitating community access to clozapine. And one of the first things that I realized when I was working in this outpatient department was that the patients that I was seeing with schizophrenia were far more complex, invariably far more complex when it came to their physical comorbidity than an awful lot of the patients that I've been seeing at the Hammersmith Hospital, at the Royal Brompton. And yet these individuals with schizophrenia very rarely saw their general practitioners, their family doctors, very rarely saw their cardiologists, etc., if they'd been referred to them. And it was really that experience that inspired both my clinical and my research work to date. Now, we're all aware of the sorry statistic of excess mortality seen in people with schizophrenia. 15 years, depending on which epidemiological study you read, the estimate is that people with schizophrenia on average will die 15 to 20 years earlier than members of the general population. And the important key take-home is that the majority of that excess mortality is due to cardiovascular disease. Now, the reasons for excess cardiovascular disease in people with schizophrenia is, of course, complex and multifactorial. Lifestyle factors play a role, increased rates of smoking, poorer diets, reduced levels of exercise. But of course, illness-related factors play a role as well. If someone has a poorly controlled psychotic illness, they are less likely to engage with physical health services, less likely to present with a problem to physical health services, and in any walk of medical life, the longer you leave something, the harder it is to treat, the poorer the outcomes as well. There's also an emerging body of evidence that psychosis as an illness in its own right may involve more than simply the brain. Maybe we should be reconceptualizing it as a multi-system disorder with glucose irregularities seen from illness onset. So there's this super added risk potentially seen in people with psychosis for developing cardiometabolic disease. But then, of course, the problem which is very worrying for us is that when a patient with schizophrenia presents to physical health services with a problem, which is usually a little bit later than a member of the general population, they are less likely to get that same gold standard quality of care that the rest of us might expect to receive. So, for example, if I were to present right now to King's College Hospital over the road from where I am with chest pain, because I thought that this talk was going particularly badly, and I was having a heart attack, and I had ECG changes showing that. My blood test results showed a raised troponin. I was having central crossing chest pain. By virtue of the fact that I don't have a diagnosis of schizophrenia on top of that, means that I am 10% more likely to have an angiogram and a stent fitted than someone with schizophrenia with exactly the same constellation of symptoms, blood test results, ECG findings. So there is a stigma attached to a label, a diagnosis of schizophrenia, meaning that our patients don't receive the same gold standard quality of care. And then, of course, far left-hand side of this graph, this diagram, we have the physiological effects of the medications that we prescribe: antipsychotics, mood stabilizers, antidepressants. These treatments are not without physical consequences, and that's going to be a key part of what I'm talking about today. What is the role of the psychiatrist or the psychiatric practitioner in the 21st century to try and improve and target the physical health of our patients with psychosis, with schizophrenia, or any patient with serious mental illness? And this is an interesting and potentially quite divisive question, because I have a number of colleagues who I work with who, quite reasonably, you would argue, said, well, I went into psychiatry because I didn't really want to deal with physical health problems. I wanted to deal with the mind and the brain and help my patients with that. So, why do I have to start thinking about physical health conditions as well as the complexity of the brain? And I would argue that it is, even if you really sort of dislike having to deal with the physical comorbidity, it is hard to avoid this component of our jobs, because there is such an overwhelming body of evidence showing this excess physical comorbidity, the comorbid burdening of our patients, overwhelming evidence to suggest that our patients don't engage typically with medical practitioners, overwhelming underlying evidence that some of the medications that we ourselves prescribe have physical consequences, meaning that it is hard not to incorporate aspects of addressing physical health conditions in our day-to-day psychiatric practice. How can we do that? Now, I'm not arguing that we necessarily have to start becoming the family doctor, becoming the general practitioner, so, prescribing the antihypertensives, the statins, etc. But I think there are aspects of care that we provide that can address all of those aspects of physical health burden that contribute to that comorbidity seen in our patients. So the number one key thing is, of course, is to appropriately manage the symptoms of our patients, because better controlled symptoms of mental illness will, we have good evidence to support this, result in better engagement with physical health services and better outcomes. And I'm confident that we're all trying to do that anyway. So hopefully we've already ticked off one of those aspects of care. So good management of psychiatric symptoms. The other thing for us to bear in mind is that we are in a very privileged position as psychiatrists in having knowledge about the excess physical comorbid burden seen in our patients that our physical health counterparts, our cardiology colleagues, our respiratory medicine colleagues, don't have. Why do I know that? How do I know that? Well, because I trained in that world, and it was only when I went into psychiatry that my eyes were opened to this issue. When I did my MRCP, my membership exams, for Royal College of Physicians, there was absolutely no information dedicated to this comorbid burden seen in patients with schizophrenia, with serious mental illness. So we are in a privileged position to educate our colleagues about problems. And that comes to this issue on the bottom right-hand corner of this diagram, is this notion of advocacy for our patients. Fighting the corner of our patients. If we see a problem, is informing our colleagues, our physical health colleagues, about the problem, and working hard to get our patients to receive the same gold standard quality of care that we might expect ourselves to receive, or our family members to receive. Bottom left-hand corner is a key issue that is really I feel very strongly about, is the notion of, if you see a problem, see a strange blood test result, a blood pressure that is slightly too high, is rather than simply documenting and moving on, is trying to do something about it. When I started working at the Maudsley 9 years or so ago, I remember people who were doing quality improvement projects, audit projects, where everyone was congratulating themselves for because they were achieving good rates of checking of observations, physical observations like blood pressure, heart rate, etc. And so we're doing a really good job here, guys. 80% of our patients had their blood pressure checked. But what annoyed me to an extent was that these blood pressures were being checked, but then they weren't being acted upon. And I would argue there's absolutely no point in checking your blood pressure if you're not willing to actually do something about it. So I think there is a real sort of drive here that if we see a problem, we should be doing something about it. I'm not necessarily saying we need to treat it, but it's by liaising with colleagues who would be able to take over that process. Top left-hand corner, I think we do need to become better at providing lifestyle interventions. That includes, the opportunity to help people stop smoking, for example, but also in terms of providing dietary and physical activity advice. And then finally, and this is the key part of my talk today, is being more physiologically minded with our prescribing. Recognizing that not all treatments that we prescribe, and antipsychotics in particular, not all of these treatments are built the same. And so, all things being equal, trying to prescribe those medications that have a little bit, that are a bit better when it comes to side effects, a bit better when it comes to physiological consequences than others, in order to try and not only improve someone's side effect profile in the here and now, but improving their outcomes in the long term, their cardiovascular outcomes and other related physical comorbid markers. So I have three main objectives for today. We're going to be thinking broadly about the impact of antipsychotic side effects, and I'm going to be focusing in particular on two key side effects in my mind in modern psychiatric practice, which is weight gain, broader metabolic dysregulation, but also raised prolactin. We're then going to move on and think about whether we can start to understand the different side effect signatures of antipsychotics based on their individual receptor binding profiles. And then finally, I'm going to describe to you a new digital tool that we've recently created, which is freely available at www.cymatic.com, I won't be offended if you have another window open at the moment and sign up now. But this is a project that we're really excited about, which facilitates evidence-based and personalized antipsychotic and antidepressant prescribing based on side effects of treatments, trying to find the treatments that are best for your patient based on their side effect concerns. So those are three main objectives, and to do that, I'm going to be describing 4 key papers that we've published recently. So side effects of antipsychotics are common. Qualitative studies that have been published tell us that about 3/4 of patients prescribed an antipsychotic will experience at least one side effect. And I would argue that it's actually higher than that. We know that if a patient with first episode psychosis takes an antipsychotic consistently, any antipsychotic consistently for about a year, 86% of those individuals will experience clinically significant weight gain. So, this is that. So we're talking about by far the majority of the patients that we prescribe an antipsychotic to will experience at least one side effect. And of course, these side effects have wide-reaching psychosocial and physiological consequences impacting quality of life and someone's ability to function, contributing to morbidity, mortality rates, contributing to stigma. And of course, one of the key aspects of our jobs as psychiatric practitioners is if someone has side effects of treatment, they are less likely to take the treatment, because why would you if you were, if you were getting nasty side effects, which increases the risk of poorly treated psychiatric illness, increasing the risk of relapse. And maybe it is not surprising in that context, but it is side effects of treatments that are of antipsychotics that are of primary importance to patients with schizophrenia when making antipsychotic decisions, when prescription decisions, actually ranking for a lot of our patients lower than actually how effective the treatment is in managing psychotic symptoms. It is side effects of treatments that is really important to our patients. So let's think about 2 key side effect groups. And the reason I've chosen weight gain and raised prolactin and the sexual side effects that are a consequence of that, because when I used to work in early intervention, working with people with first episode psychosis, it was those 2 side effect profiles that were really key importance to the patients I was seeing. And that's reflected in this quotation here from a user group, a patient group, support group that I ran last year. And this is a quotation from the mother of a patient with first episode psychosis who said, "My son's illness improves with antipsychotic medication, but the weight gain is awful. He stops treatment because of weight." And of course, it's not just about weight. We focus on weight because it is a risk factor for broader metabolic dysregulation, which we know is highly prevalent in our patients. So patients with schizophrenia across the age range have increased rates of all of those components of the metabolic syndrome, look at rates of 3 to 5 times higher compared to members of the general population. And half of our patients have the metabolic syndrome, which translates into that increased cardiovascular risk. Now, it is sometimes when I give a talk like this, I get a bit concerned that people will walk away from the talk thinking, "Oh God, I can't prescribe antipsychotics anymore because they're really bad treatments. They've got all these side effects, and I'm going to cause more harm than good." So it is important to recognise that there is robust data from Jari Tahonen's group, in particular from Finland and Sweden, which has shown that if you have schizophrenia and you are prescribed an antipsychotic, you will, on average, live longer than someone with schizophrenia who's not prescribed an antipsychotic. And that is shown in this paper and the diagram, the Kaplan-Meier survival plot that is shown on this slide here. So Jari Tahonen and his group published a landmark study in 2012, which looked at the mortality rates of people with schizophrenia over a 12-year period. And then in 2020, in World Psychiatry, they published an updated paper looking at the life expectancy of people with schizophrenia, and we're talking tens of thousands of patients here over a 20-year period. And that's exactly what's shown in this graph on this slide. You have on the x-axis the time taken the time over which the individuals were looked at, so from 0 to 20 years. And then on the y-axis, you've got the likelihood of the patient being alive, survival probability. And at the beginning of the study, at time 0, everyone's alive. You've got 100% survival probability. But what Jari Tohonen's group did is they divided that group into two, and they have the light grey line shows the survival probability of people with schizophrenia prescribed an antipsychotic, and the black line shows the survival probability of those with schizophrenia who are not prescribed an antipsychotic. As you can see, at any one point in time, the light grey line is higher than the black line, so you have a greater survival probability if you are prescribed antipsychotics. Now, that sounds a bit confusing to me, because on one hand I'm saying, well, you know, people who are prescribed antipsychotics will have greater side effect burden, cardiovascular disease risk, and they will die of heart attacks or strokes earlier. But on the other hand, I'm saying that actually if you're prescribed an antipsychotic and you have schizophrenia, you will live longer. How do I marry those conflicting arguments? Well, I'm going to try and show you how we do that through this schematic here. So this is a diagram that shows you the estimated lifespan of someone from the general population without mental illness. That's the blue bar, compared with the life expectancy of someone with schizophrenia. That's the green bar. And unfortunately, individuals with schizophrenia are dying earlier. So on the x-axis, you've got number of years lived. Now, if we prescribe an antipsychotic, someone with schizophrenia, then their life expectancy increases. And we recognize that that is through, especially at the beginning of the illness, early treatment, and leading to reductions in death by suicide, reductions in death by misadventure. But more recently, we've got some good, robust data that shows that people with schizophrenia prescribed antipsychotics are more likely to engage with physical health services and have better outcomes as a consequence of that. So they keep seeing their GP, they keep seeing their family doctor, they keep seeing their cardiologist with better outcomes, and they keep taking their cardiovascular medications with better outcomes as a consequence. However, we recognize that these treatments that we're prescribing also have side effects, increasing cardiometabolic risk being one of them, leading to reductions in years lived. But the key take-home message here is that we are gaining more years than we are losing through antipsychotic prescription. So there is a net gain in years lived. So the key point for me is, if we recognize that different antipsychotics have different side effect profiles when it comes to cardiometabolic risk, then surely we should be aiming to use those treatments with lower cardiovascular risk compared to those with higher cardiometabolic risk, thereby reducing those, increasing the net gain essentially of our patients. And that was the inspiration behind a paper that we published actually 3 years ago now, time has flown, which looked at 18 commonly prescribed antipsychotics prescribed in the treatment of schizophrenia, acute treatment, so a median duration of 6 weeks. And what we wanted to do in this study was to rank treatments based on the magnitude of change in different metabolic parameters to guide our prescribing practice. Now, we don't have time to go through all of the study objectives for this paper, and those of you who've seen me speak before will have seen me go through these, so I will try and just give you the key take-home messages from this study. But the key thing that we did here was to get robust data from double-blind randomized controlled trials and look at change in metabolic parameters over the study duration. And remember, this was an acute treatment of schizophrenia, so a 6-week duration on average. And we were looking at change in weight, change in body mass index, change in glucose, cholesterol, lipids, triglycerides, etc. And we gathered data from 100 randomized controlled trials, nearly 26,000 patients, and 18 antipsychotics. Got a few forest plots to show you, which I'm going to very briefly give you the key take-home messages for, just to get your eyes into and acclimatize to this. We've got 2 forest plots here. The first one on the left is looking at change in weight with different antipsychotics. The one on the right is looking at change in body mass index. You have all the different antipsychotics on the left-hand side. On the x-axis for this graph on the left, you've got the mean change in weight, 0 to 4 kilograms increase in weight. If you are to the right of this vertical dotted line, you have an increase in that given metabolic parameter compared to placebo. Now, the results for some of these metabolic parameters will not be surprising to those of you who are prescribing antipsychotics on a regular basis. drugs like olanzapine, clozapine, quetiapine, significant increases in weight over a relatively short period of time, looking at least 3 kilograms if weight changed. Similar picture with drugs like clozapine and olanzapine when it comes to body mass index change, looking at on average a 1 kilogram per meter squared increase in a month and a half. Same picture with total cholesterol, which we're looking at here on the left, increases with quetiapine, olanzapine, clozapine. What was interesting when we started to look at other metabolic parameters, and we showed some surprising findings where we showed that suddenly some antipsychotics were outperforming placebo. So that's shown on the right-hand side of this graph here, where we looked at so-called bad cholesterol, LDL cholesterol. Again, at the bottom, drugs like quetiapine and olanzapine clearly resulting in an increase in bad cholesterol. But look at the top of this forest plot. Cariprazine, relatively new kid on the block, although maybe not so now, relatively well established now, but a partial agonist, so relative of aripiprazole and brexpiprazole, associated with significant reductions in LDL cholesterol. And we also looked at HDL cholesterol, where the other 2 partial agonists we looked at were associated with significant increases in good cholesterol. So all things being equal, we were starting to identify that there were some antipsychotics that were clearly had better metabolic side effect profiles compared to others. And we wanted to summarize all of that data in a heat map that could arguably be used in day-to-day clinical practice. So in this heat map here, you've got all the metabolic parameters that we looked at: weight gain, body mass index, glucose, etc. And on the left-hand side, down the side, you've got all the different antipsychotic agents that we looked at. And the hotter the square is, the redder the square is, the greater the magnitude of change with that metabolic parameter. So, for example, if I then saw a patient in my clinic and they already had diabetes, for example, with raised sugars, then they might say, well, I'd like to avoid an antipsychotic down here at the bottom in this third column, which has very red squares, and I'd like to try and have a drug with slightly lighter squares at the top. So that was the rationale behind this heat map. It's actually been superseded by this digital tool that I'm going to describe to you later on today. But it is a nice summary, I think, of the different metabolic profiles seen for different treatments, and giving a very clear evidence that not all antipsychotics are built the same when it comes to metabolic side effects. And indeed, it was data from that study that informed the evidence that we provided in the Morse Practice Guidelines for Physical Health Conditions in Psychiatry in the obesity chapter, where we were saying if you wanted to be metabolically minded in your prescribing, then ideally, and this is a diagram taken from that obesity chapter, which was based directly on our Lancet Psychiatry paper, which said all things being equal, if you want to be metabolically minded, then you want to be trying to aim to prescribe these treatments down here at the bottom compared to these treatments down here at the top. And also, one of the criticisms of the paper that I've just shown you is that we limited our research and our CT data extraction to working age, to people who are aged 18 and above, and we didn't include people from the pediatric child and adolescent population. And so this is work that isn't published yet. We're just going through the review process at the moment, just to have to resubmit some comments, which is work led by Dr. Maria Roltaki, also at King's College London, who did essentially exactly the same project, but looked at use of antipsychotics in children and adolescents. And essentially the take-home message here was a slightly smaller pool of data, about 6,000 children and adolescents with a mean age of 15, treated for slightly longer, 12 weeks. But the take-home message here is that essentially you see a very similar signature of metabolic side effects and broader physiological side effects, where you have, again, we're just showing you data from the change in body weight and change in body mass index with these treatments. Drugs like quetiapine at the bottom, olanzapine, clozapine, you can see they're way over to the right in terms of increased weight in these young people. Are looking at around 4 to 5 kilograms increase of weight, BMI increasing by about 1 to 2 as well. Whereas at the other end of the spectrum, you've got the partial agonists, lorazepam, etc., which have superior metabolic side effects. So I think the key take-home message there is that I think we have robust data now that shows that there are some treatments that are better than others when it comes to metabolic side effects. But what about prolactin? Well, the interesting thing with prolactin is that although we focus a lot, and reasonably so, on the role of antipsychotics in causing raised prolactin, as an interesting academic side comment, you actually see raised prolactin in people who are antipsychotic naive with first episode psychosis. And the rationale, the understanding of why you see that, and that's the reason I say that is that someone has done a meta-analysis, which I've shown you the schematic here at the bottom, reflecting that, looking at increased prolactin levels in patients with first psychosis compared to controls. And the understanding is that prolactin is released as part of a stress response, in terms of it sort of accompanies corticosteroid, etc., blunted cortisol awakening response, and that is why you see raised prolactin in drug-naive first episode psychosis. But the degree of prolactin increase in first episode psychosis is completely blown out of the water compared to the degree of prolactin increase that you get with treatments. And I won't patronize you guys. Of course, you all know the mechanisms by which you get raised prolactin with antipsychotics, blocking dopamine receptors in the at the end of the tuberomandibular pathway at the level of the pituitary gland, which is in that pathway, the dopamine is acting as a handbrake on prolactin release. So as soon as you block those receptors, the handbrake is released and prolactin is released into the bloodstream. And Stefan Leut, in his most recent iteration of looking at antipsychotic efficacy, also published in 2019 in The Lancet, a network meta-analysis looking at comparatively across antipsychotic systems the magnitude of prolactin increase. We know that and that is shown, the forest prolactin is shown here on the right. The biggest culprits for raised prolactin, and we all know this as well, is the so-called first generation antipsychotics, but also haloperidol, risperidone, amisulpride, and sulfur. Now, we've also looked at this ourselves, urea, in children and adolescents, in that same project that I showed you before that's in submission at the moment, where we looked at increases in prolactin across different antipsychotics in young people, and it's exactly the same picture again. Look at the bottom of it. So we've got a forest plot here, which is showing all the different antipsychotics on the left-hand side, and then the x-axis, you've got the change in prolactin levels in the blood. If you're to the right of the vertical dotted line, you've got an increase with that given treatment. And again, as shown in the Stefan Leut paper from 2019, which was looking in adults, in children and adolescents, it's exactly the same picture. It's risperidone and haloperidol of all the treatments that we are able to look at. It is by far the worst culprit. And at the other end of the spectrum, you've got the partial agonist aripiprazole, which is the best option, which again, I think, everyone would agree is part of their clinical practice, their experience of clinical practice. Now, we all know that the raised prolactin can be asymptomatic, but it can, if you get to a certain level, start to have short-term side effects, which involve sexual dysfunction, problems with skin, if you're female, impacting menstrual cycle. But what's I'm interested in with regards to that paper that we've got in submission as well is the implications in children when it comes to impacting puberty, but also bone development and osteoporosis, because that is a real concern for our adult population, is that consistent use of prolactin increasing antipsychotics may be increasing the risk of osteoporosis and may be increasing the risk of malignancy. We know, for example, that people with schizophrenia are something like 7 times more likely to have bone fractures than members of the general population. And the malignancy issue is something that is really interesting. And this was looked at again by Jari Tehonen's group a couple of years ago in the Lancet Psychiatry, which was looking at breast cancer risk. Now, because of the influence of prolactin on broader sex hormones, there is a hypothetical link made between raised prolactin and increased risk of breast cancer. But this has always been a theoretical concern rather than anyone actually joining the dots in a specific research study until Jari Tehonen's group was published 2 years ago. And this was an interesting study which looked at 30, I think they took data from 30,000 women, people with schizophrenia, They looked at a specific sample of 6,000 women, and they looked at rates of breast cancer in these women with schizophrenia, who were all treated with antipsychotics, but then they compared the rates of breast cancer depending on what type of antipsychotic they were receiving and the duration of antipsychotic treatment. And they subdivided the types of antipsychotics into two groups, the so-called prolactin increasing antipsychotics and the so-called prolactin not increasing antipsychotics. Or prolactin sparing antipsychotics, I think is the term they used. And again, this is going back to my previous slide, saying that the prolactin increasing were the first generation antipsychotics, risperidone, etc. Prolactin sparing, drugs like quetiapine, olanzapine, potassium agonists. And what was very clear is that the biggest margin of effect was if you were prescribed a prolactin increasing antipsychotic for 5 years or more, then compared to a patient prescribed that same type of antipsychotic for only 1 year, your relative risk of having of breast cancer increased by 56%, which translates into an absolute risk of increased breast cancer of 4%, which is deemed to be clinically meaningful. Now, of course, the key thing to remember here, and there are always caveats with these sort of studies, but the key thing to recognize is that this is not a study that is looking at the direct effect of prolactin. None of these patients had prolactin levels measured. We are indirectly assuming that it is the prolactin increase and the consequence of treatment that is resulting in the breast cancer increased risk, but we don't know that. We're making that assumption. It is the closest we've ever got as a field to showing that by taking a prolactin increasing antipsychotic for a prolonged period of time, 5 years or more, is significantly increasing, for females, breast cancer risk. And this actually comes back down to a key point about side effects of treatment that I think is important for us to remember as psychiatric practitioners, is that sometimes I think we respond instinctively to acute side effects. So people putting weight on in a few weeks, people having sexual side effects of respiratory, people developing movement side effects in the here and now. I think often we don't necessarily have one eye on the future and the long-term consequences of side effects, such as cardiovascular disease risk, breast cancer risk. And this is a key point that was actually raised by a project that I was involved with about 4 years ago now, the Lancet Psychiatry Commission for Improving the Physical Health of People with Serious Mental Illness. And a key action point from this paper was that actually we need to be getting better at not just thinking about side effects in the here and now, but side effects in the long term. And how do we combat those? How do we reduce those heart attacks in 10, 15 years' time? How do we reduce those rates of breast cancer in 10 to 15 years' time? The question is, if you do see someone with raised prolactin and you think that it's antipsychotic related, what do you do? And this is a great example of how as soon as you write something, it's out of date. What do I mean by that? Well, again, in Mark Maudsley Practice Guidelines for Physical Health Conditions in Psychiatry, great book, available at all good bookstores, we had a prolactin chapter. And when we wrote it, and we wrote it with an endocrinologist from King's College Hospital, the key question was, well, what do you do in someone with raised prolactin, but they're asymptomatic, and the prolactin level isn't too high? And, the conclusion from one of our endocrinologists was, well, actually, you know what, if they're asymptomatic and it's not too high, it's raised, but it's not massively raised, you can have a discussion with the individual, but you could argue that it's reasonable just to leave things as they are, don't change treatment, and just keep an eye on things. But now that we've got that Yara Tohonen data, I would argue that I would be, even in people who are asymptomatic, but with a raised prolactin level, I'd be thinking maybe we want to do something about this raised prolactin. Certainly, if I were prescribed an antipsychotic and I had raised prolactin, or I had a sister who was prescribed an antipsychotic and had raised prolactin, I personally, giving it the sister test or your personal test, I would want something done about it. And if you are going to do something about it, I guess you have 3 options available to you, although I would argue you actually really only have 2 options available to you. Some people advocate that you can give a trial of a dose reduction of an antipsychotic. I would argue that invariably that isn't effective. And the reason being for that is that the dose that one requires typically to have a therapeutic benefit with regards to reducing the burden of psychotic symptoms is typically far higher than the dose that is required. That's probably the wrong word, but is responsible for causing raised prolactin. So even by reducing the antipsychotic dose a little bit, but whilst trying to really maintain that therapeutic level for treating psychotic symptoms, is probably not going to be effective in managing the hyperprolactinemia. So you're essentially left with two options. You can either switch that antipsychotic to an agent with lower associated hyperprolactinemia risk, or you can augment with a partial agonist, which is typically usually effective, but it must be noted that it's not usually effective if you're trying to augment amisulpride. Again, I think this is something to do with the doses that are required of amisulpride to cross the blood-brain barrier. It doesn't matter what dose of partial agonist you give, it's typically ineffective in terms of managing raised prolactin. The take-home message for this bit of the talk is that we know this already. Of course, you know this already, but antipsychotics have rapid effects on people's metabolic parameters. No matter in a few weeks, you're looking at clinically significant changes in weight, changes in lipids, changes in glucose. I didn't mention it before, but the increase in triglycerides that patients get on average with a drug like clozapine, which is about 1 millimole per litre increase in triglycerides, that translates into a 30 to 70% increase in cardiovascular risk. So these are clinically significant changes in metabolic parameters. If we're thinking about treatments that are better than others in terms of metabolic side effects, we've got 5 treatments really that seem to be better. We've got the 3 partial agonists, A, B, C, aripiprazole, brexpiprazole, and cariprazine, and then the sister molecules, the ziprasidone and the residone. When it comes to raised prolactin, the good news is that those treatments that are good for metabolic side effects are actually pretty good for raised prolactin, of course. But I think the key take-home message that I would hope for you guys to take away from this bit of the talk is that actually I think we need to start thinking about prolactin and raised prolactin in the long term in terms of the consequences, and actually thinking about intervening in situations where someone historically might have just ignored the modestly raised prolactin that is asymptomatic, or as an absolute minimum, simply having a discussion with your patient and coming up with a plan. Are you happy with this raised prolactin, bearing in mind the potential risk that might be associated with that over a long time period? So we've talked about the impact of antipsychotic side effects, and now I'd like to move on to whether we can understand antipsychotic side effects based on their receptor binding profiles. And to do that, I'm going to describe a paper that we published this year that was led by Dr. Rob McCutcheon at Oxford University, which I think is a very elegant study, which I'm delighted to briefly summarize for you guys. Now, we know that antipsychotics have a common, maybe put clozapine aside, where we're slightly more in the dark, but generally speaking, we have a good understanding of why antipsychotics are therapeutically beneficial to the majority of patients who are prescribed it. And what I mean by that is that they target dopamine receptors. But we also know that antipsychotics tend to be far more diffuse in terms of their pharmacology, and are binding to an awful lot of receptors around the brain and the body that may, which result in different side effect profiles, but also maybe differences in efficacy from one drug to the next. Now, we also live in an age where there have been a number of preclinical studies published over the years that are human clone receptor studies that tell us how tightly these different antipsychotics bind to different receptors within the brain or within the body. So we're talking about more than just dopamine receptors here. We're talking about muscarinic receptors, serotonergic receptors, histinergic receptors, adrenergic receptors.